and we're just going to do a Cahoots. Now, this is chapters 37, 38, 39 is about cognition. It's also about disability, and it's also about variations in care. Now, when you think of care of an infant, it's different than it is from an adult. We know the vital signs are different. We know drawing blood is different. And those are the things that we're looking for in that variations of care. That's all what that means. It's those differences that you have to understand in order to take care of a child or in order to take care of an adult. So what I decided to do, because it's easiest for you and I could talk over it and I can make sure that you understand it, is I'm going to do a Cahoots and I'm going to talk about all the concepts you need to know. Now, I did send you, who's not on mute? There you are. Got you. What I do suggest is I did send you a PowerPoint. Just go through it, read it, look at those areas, those topics there, okay? Because as we know, exams are going to be, some are off the PowerPoints, some are off the Cahoots, and some are off the study guide. Of course, mostly study guide, but Cahoots also, and your PowerPoints. So make sure that you do look, especially chapter 39, all right? So let's go ahead. And after that, your brains are dead. You've had 2 exams. Let's do a Cahoots and let's see who's going to win this one on really new information. I don't know how many students would have gone and even looked at it already with what's on your plate right now. Who else is coming in tonight to play? Anybody else coming?
Mine's taking forever to load. I'm trying. I've already had to restart it twice.
Wow. All right, we'll get going. When you catch up, you catch up. Just listen to it and look at the answers, okay? So week 4, 1/3 of the way through already. It's quite amazing how quick this goes. Early detection of a hearing impairment is critical. Which one is of primary importance? Well, when we talk about sensory problems, it's hearing and sight, and speech. Hearing is affected by what? And what is affected by hearing?
Speech.
That's absolutely it. So you have a child who can't speak correctly or is garbling. The first thing you're going to do is do an evaluation of the speech. Find out and the hearing. Can they hear good? And if they can't hear good, that's the reason. So then we would give, if they need a hearing aid or even further surgery, that's what we would look at. So hearing, speech go together. Remember that. A multi. Toddlers playing outside get a laceration on the forearm and he needs stitches. What can make this easier? Now, this is a toddler, age 1 to 3. They've cut their arms, and you know what they feel about their insides coming out and bleeding everywhere, right? They're screaming and yelling and going bonkers, and they're scared of you. So what can we do? Numbing cream, that's the number one. And then have you ever heard of child life before? Now, child life is a group of very well educated, a minimum of a bachelor degree. Many of them have doctoral degrees on how the developmental stages of children are. And what they let them do is explain to them what things are. Now, would you let them see a suture needle for suturing? No. What you would do is tell them, maybe you might show them a clamp or a forcep, but even that looks really scary to a child. So get the child life involved. They'll describe it. Get that numbing cream on. Let them know they'll have touch, no pain, and distraction. Put up give them an iPad, let them play a game, let them watch a movie, a video. All of those things can help that make it so much easier. A parent recognizes that a toddler has a speech delay compared to their older siblings. What is your priority as a nurse? Speech delay. What do you do first? Now, number one, priority, get that hearing evaluation. Yes, all children do progress differently. Absolutely. But your priority, that's the question. Priority is get them for the hearing evaluation. Once they get the hearing evaluation, it's okay. And then it's going to be speech therapy. If it's really behind. But again, yes, all kids are different. A multi. What are signs of an early indicator of an impaired cognition? Remember, cognition is how you think. That means your mind, your central nervous system. Something's not going right there. What would you see? Now you wonder why we teach you all these developmental levels and growth skills that they do. It's because we're looking at their brains and how they're thinking, and is their brains working correctly, which is their cognition. Well, if they're not saying one word by 1 year, mama, dad, milk, something, that is an early indicator. Unable to grasp an object by 7 months. Remember, there's a reflex that we do, very quickly after birth. And then it's more of the voluntary. And at 7 months, they have to be able to at least grasp. They should change hands by 7 months. And the other thing is, even in older children, behavior difficulties. They can't speak, they can't explain themselves, they're very frustrated, they just are out of their minds and they just act out. And that's what I would do if I couldn't explain myself and if you didn't understand me. And that's why behavior difficulties. We see that a lot in the autistic children, the behavior difficulties. They can't express themselves. A child's being treated for a fever. The reason for treating the child's fever is what? We know we treat a fever because we want them to feel better. We want them to eat and drink and be up and moving, because when they have a fever, they're not moving. They're in the corner, not feeling well, not eating, drinking. And the major reason is that relief of discomfort. How do you feel with a fever? You feel miserable, aches and pains and miserable. Fever comes down, you feel a little better, right? You can eat or drink something. Now, the prevention of life-threatening complications, seizures is what you're worried about, right? Well, febrile seizures, once you have a seizure, have a fever, you're not going to have a febrile seizure, because that febrile seizure is from no fever. 20 minutes later, you go from 98 to 101. And that rate of rise, that quick rise, is what causes seizures. I've seen children with close to 107 temperatures. I've never seen a seizure from a fever. Okay. So it's not life-threatening complications. You're making them feel better, so they'll drink. A multi. The child's complaining there's something in their eye causing tearing and pain. What is your nursing action? Now, children are always getting things in their eyes, falling down, running into things. When do we know we can do something when we can't? And what do we need to do? Well, first of all, if stuff is floating around, you can take a tissue and you can remove it very easily. If there's anything sticking into the eye, we do not flush the eye. We do not do anything. We put a hard, and it's called a Fox shield. It's like a cotton iPad, but it's hard so that it doesn't mush into the eye, looking at that penetrating object and making it move. So it protects it until, and you do both eyes actually, and you get them to a pediatric, excuse me, ophthalmologist or a pediatric emergency room. And then they could take care of it. Because if we pull it out, we could ruin the eye. And yes, the other thing is always check the reaction to light, and we could see how much damage that is. And at that point, Fox shields them, get them to where they need to go. Separation anxiety in a child hospitalized. Which behavior indicates the stage of despair? Now, this is a big deal, a big concept that you should know. Separation anxiety is 3 stages. And what does it mean? Well, toddlers especially, put them in a hospital and mommy has to go home. That toddler's going to scream and yell and go bonkers. They want mommy, 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 mommy. So the second stage is where they get that despair, is like they realize mommy and daddy's not coming. All right. And they regress. They start sucking their thumb again, or they're potty trained and they are incontinent. These are behaviors of the second stage of separation anxiety. The third stage is when, and depending on how long mom or dad or a caregiver has to take to get back to the child, they might even ignore them and only play with the nurse or the aide who's been, playing with them all of this time, okay? And of course, these children, parents can't be there. That consistency in caregivers, same nurse, same, techs in there, that is what we have to do. That helps. A child with a history of abuse. Which therapy explores emotional problems? And a lot of times we do this with child life. They're very aware of this, or maybe even a psychologist in there watching what's going on. What's the one thing that is non-threatening to a child? And it is play, right? Children will play no matter what. Especially you give them the toy that they want to do. So it's just overall, just specifically just play therapy. Okay. Another multi. When can children react to the stress and anxiety to a hospitalization? Children in a hospital, it's pretty stressful. Children don't like change in routines, and they do not like to be away from their mother or father, their caregiver, or nana, or the pop or whoever it is. And they can really stress before, when they know it's actually too early, and after they go home. Now, yes, they'll stress during the hospitalization, but it's, before, during, and after. And sometimes that stress, if they have to come into the hospital again, can make it even more stressful, okay? So before and after they go home. A multi-select. An adolescent goes to the ER for treatment without a parent. How do you get consent for treatment? I know every NCLEX has a question about consents and children and how you work with it. So that's why I make sure we have one here. Now, 18 years old, they are competent, awake, and alert, can sign for their own treatment. Also, as a nurse, be careful. That parent needs that child's permission to understand lab works, x-ray reports, or what's going on, okay? That 18-year-old is now in charge. Now, the other thing is children who come in, even adults at that point, come in an emergency situation. You know, the trauma brings them in and they need care. You do not need a consent. If it's life-threatening, you need to do the treatment and then get the consent as soon as you can. The other way is if you have time, and it could be the ER clerks, they call up the parents and two people listen to it and they get the consent, okay? And it's not any 18-year-old child. Remember that you have cognitively delayed children. Those are not. So it has to be deemed competent. A child is extremely fearful of hospitalization. What type of play explores these fears? This could have been one who was stressful the first time, right? And now they're afraid they're coming in again. We got to find out what has caused these fears, right? And how do we eliminate them? And it's called dramatic play. Dramatic play is you give them dolls and equipment and see what they're doing with it. And we could tell by what's been happening where that fear was started through just play. It's non-threatening. Play is always fun. When checking the IV on an infant, you notice the tissue around the IV is swollen. Your first action is what? Remember, IVs in infants can be running at 10 or 12 mLs an hour, which is not a lot. But make that child 3 pounds. It's a lot of fluid being pushed into the tissue, right? And you can get an infiltrate really easily and cause a lot of skin damage. So, number one thing on an infant, you stop the infusion. Then you can inspect it and see if it's salvageable or you have to restart one. In helping a child to adapt to a hospitalization experience, the best approach is well, number one is have mom room in, but what's else? And it's keeping them on that routine. Now, yes, can we bring toys? Of course, but number one is always parents rooming in. Absolutely, give them that comfort of parents. But number two, and just as important, is that daily routine and schedule, or that ritualism. Keep them in the same experiences. Now, you can have them bring toys, a pillow, pajamas, their own binky, whatever it is they like. Absolutely. But it is that routine that is extremely important. When assessing vision on a child, the healthcare provider would use a Snellen chart. At what distance? And you know, young kids can use Snellen charts, but they're not going to be letters unless they know letters, right? They'll be shapes, maybe arrows pointing up and down and sideways. And it's at 20 feet. If they're not seeing it 20 feet and you know it takes closer to see it, you know, this is something we would notify our healthcare provider about so they can do a further investigation of their eyes. Another multi, nursing care of discharging a child to home. If you've had a child, whether an outpatient procedure or inpatient, they're going home. What do you need to do to discharge them properly? So we will provide instructions to the parents and the child if they're old enough. So that's why that one is not correct. But always emergency phone number, the doctor, the surgeon, expected outcomes. What do you expect to see today, tomorrow, and the next day? And what is normal? I mean, a little bit of bleeding, is that normal? Or is it not? And that's important for parents to know. And ensure that the parents do understand Let them repeat what you have said about what is expected, what to call a physician for, etc. What does a child need to have? What is a 3-year-old's biggest stressor of being hospitalized? Biggest. Like that's the end of the toddlers, beginning of the preschoolers. Biggest stress. All of them are stress to them. What's the biggest? And it's the parents. Separation from parents. They want to be around the parents because that's, the person who takes care of them, that's loved them, that kept them safe. They want their parents. Another multi. What is the best way to alleviate the stress and anxiety of a hospitalized child? Here we are. So we do not do invasive procedures at the bedside. We want that bed and that room to be a safe place for the child. Usually they'll take them out into a procedure room to even restart an IV, just to keep their room safe. So keep the child in the same routines, just like I said, have the parents stay, and always explain those procedures on a developmentally appropriate terminology. Does the kid understand what you're telling them? A nurse notes the string tied around an infant's wrist, and an appropriate nursing intervention would be. I mean, is it normal for a string to be around an infant's wrist? I mean, that's the first thing. So, what do you think it could be? And always, when you don't understand, you see something you don't know, always ask the parents. I know when I first started in pediatrics and working in Miami, there's these little black eyes, or actually I have a blue eye, that they put on a wrist or on a pendant, or on a necklace on infants. And what I found out is that it wards away bad thoughts against them. It keeps them safe. It makes them get better quicker. So how did I learn that? Because I asked the parents and they let me know what their feelings are about it. How can a hearing impairment develop? Well, it could really occur from anything. I think the biggest one and the biggest concern is those chronic ear infections. We don't treat them correctly. We don't go back to make sure that the infection is gone. If the child doesn't take the entire dose of antibiotics, these are things that can leave lingering ear infections and can cause problems with hearing. Yes, it can be present at birth, could be a birth defect, and it could be caused from some illnesses also. Which urine collection method on an infant is most accurate? And it is a straight catheterization. Now, many parents are upset when I say I have to catheterize your infant. Many males with their fathers go, "Oh no, you're going to hurt him." Now, we do use the smallest collection. We use a lot of lubrication. We use a pacifier with sugar water, which helps that pain, right? And it gets a very accurate specimen. And why do we need it accurate? Well, think about an infant. They don't have an immune system yet, do they? So we really want to get that first antibiotic to work. because we don't want to have to continually change antibiotics to try to figure out what is that bacteria and what do we antibiotic we need to, get rid of it. Now, in a bag urine, there's always skin contaminants, and you always have some sort of contaminants there, and it's not accurate enough. And we need the first time an accurate one, and that's the reason why. A multi. What is the purpose and the function of a family? It's the safe environment, it's emotional comfort, and it's the values and attitudes of, the financial assistance. Yeah, it's there, but it's not the function and purpose. It's all of the other ones. The primary goal in caring for the child with cognitive impairment is to what? You have a child who's, physically, mentally not where they should be. Could be a Down child, could be an autistic child. What is our goal? And that is to promote optimum development. Many years ago when I was in high school, I used to go and do volunteer work for this agency that had cognitively delayed children and young adults. And all they did back then, and now this is, a few years ago, 40, 50 years ago, and all they did was to get them out of bed, to feed them, to change them. It wasn't any speech, physical, occupational therapy. So they weren't learning. Today, I have seen doing clinicals, this little boy, nonverbal, cerebral palsy, has a little iPad, and he could talk to us his needs. And he was being taught shapes and colors and numbers. He was 7 years old. Now, years ago, they didn't do that. And now this child is learning. And I think that really describes optimum development. And once he learned something, they gave him more goals to do. And that's better than just feeding them and changing them and in and out of bed, isn't it? It gives them a purpose in life. Many infants require oxygen. What type is best tolerated and accurately delivered? And it is an oxyhood, and this is the reason. Nasal cannula is what most other students chose. It's little two things stick up in the nose and they tickle, they bother them. And this little tube here, and we usually tape it to their chins. It doesn't go around their ears and under their neck like adults. And it bothers them and they pull it off. So they don't tolerate it. Oxyhood, it's a clear hood. They look around. It's oxygen. We can monitor how much, and they can suck on their pacifier and they get what they need. It is the best way. And if you've ever been intubated, it is not fun. I have been, and you choke and you gag on it. What is the best practice for school-age children with special needs? So special needs children, they could be sight problems, hearing problems. They could not walk. They're in wheelchairs, but they're alert, cognitively aware. Why shouldn't they be with regular classrooms? I had a girlfriend whose daughter had a stroke on her speech center at birth. Very awake, alert, smart girl, but she couldn't talk. So she had her pad and she could express herself in a pad in regular classrooms. And she's in high school now. She's doing really well. A multi. Collecting a heel stick blood specimen on an infant. How do you do it? The only IV or needle stick that we do on an infant is usually for blood cultures or for bleeding coagulopathies like a PT or a APTT, but we usually just do the heel. Now there are tricks with it. Number one, you don't go in the middle of the heel, right here. That's where their calcaneus bones is. And if that lancet you got was too big, you can cause an osteomyelitis of the heel. So it's on the outer aspects. Also, you put a warmer that is hospital approved. Infants can burn their skin on just heated out of the tap water. So make sure it's a hospital approved warmer. And the other thing I'll tell you is to not put the foot up, put it below the heart. I used to hang it over the bed and slowly, easily squeeze it. And because if you squeeze it too hard, that whole heel is going to turn purple. And that's what you don't want to do because that's the way you draw blood on these infants. And you have to go and touch that bruise again tomorrow. That'd be hurting. Referrals for cognitive impairment should occur when? As soon as you know. And that's why we do all those developmental milestones and why as nurses and professionals, we learn that because we can institute it quick. And what's so great and resilient about pediatrics is that children catch up quick. Once you institute some sort of therapy, they learn it quick, they catch up, they just want to, they're thirsty. So as soon as you can, you institute it. Down's children have frequent upper respiratory infections. And why? Upper respiratories. Now, all of them could be here, but one is the main reason. They have this flat, undeveloped nasal bone, and mucus gets caught there, and mucus drips back into their throat. And that's what causes the frequent urinary tract infections. What would be included in a care plan of a patient with moderate cognitive impairment? And it's a little bit of everything. Structured routine, that ritualism, right? Then you're exposing them to sight, sound, sensations, good toys. But remember, safe. Small things always go in the mouth. So that's the one thing we have to work about. And also toys that can teach a useful skill. I've got to run for a second to the ladies' room. I'll be right back. I can't wait. Hold on. Give me two. I apologize and thank you. I tried to hold it, I couldn't. A multi-select. Autistic children demonstrate which behaviors? So autistic children, we usually do not diagnose them till about 2 years old. Now they might show some behaviors for that, but usually the diagnosis doesn't come till then. What you see is those language delays. They avoid it's eye contact. They always will be sitting by themselves, playing, doing repetitive sort of things. They'll take a toy and put it on a chair, and then they'll take something else and put it on top, and they'll take the thing on top, bring it down, take the toy down, and they'll go over and over again. And they do not respond to their name. They don't like textures. They don't like loud noises, lights. All of these things are very specific to an autistic children. Now, through routine, through, that consistency, I've seen some autistic children do extremely well. Multi. Children with autism have better outcomes if? Again, structured routine. You have to teach them how to communicate in some way, if it's not verbal, in some way. And just because they're autistic doesn't mean they can have unacceptable behaviors. Make sure that they know what is expected of them through that routine and keep to it and don't, waylay from it. I've actually seen a Downs autistic child go into this daycare, which what I did the clinicals at, would take off his backpack, put it in the cubby, sit down, and wait for vital signs. Now that's an autistic child. They usually don't. Once he was done, they said he could go. He would go off in the corner and would play with his toys. Die. Fragile X causes. Now, Fragile X is the second most common cognitive delayed syndrome, second to Down syndrome. Now, Down syndrome and this one, there's similarities and there's some that's not the same. Yes, there's intellectual disabilities, learning disabilities, but there's also more physical, like there's long jaws, big ears, and these children are aggressive. Many of them require medication to keep them calm. So that's the difference, Downs versus Fragile X. Causes of autism. What causes it? Is it the chickenpox vaccine that came out several years ago? Just to let you know that the physician who put out that phony report does not practice anymore. And immunizations are not a cause of autism. It's because chickenpox vaccine is given the same time, about that 2 year, where we do the diagnosis of autism. So that's where they try to bring it together. But it's genetics. We don't know. Abnormalities in brain. We really don't know. So it's a little bit of everything. Ways children with hearing impairments communicate with others. And I could go beyond this to say children with two different languages, how do they communicate, right? And it's sign language, finger, yes, lip reading, all of the above. I mean, children are resilient. Put them together, and if they're alert and want to play, they're going to learn how to talk to each other some way. Amblyopia. This is one of the dysfunctions of the eye. There are 3 different ones you need to know. Amblyopia is one of them. And it's called a lazy eye. Ever see a child or even adult with an eye that one sort of moves outward or inward and it's just not straight up? Well, that's called amblyopia. Now, what's wrong with the eye? Is the muscle is not weak and it needs strengthening. So what do? They cover the good eye and say, okay, bad eye muscle, start working, strengthening up, and usually that's all they need to correct it. How would you encourage a preschooler to be less apprehensive when taking their vital signs? Remember, preschooler, ages 3 to 6. So what you do is, again, let the children play with the toys and stuff like that. That does always help. You know, again, don't let them see the needles, those things that will help them. And to tell them it's not going to hurt, they don't believe you because we are people that always have needles that sometimes they hurt. It's going to hurt a little, tell them it's going to hurt a little. What child may be more stressed when hospitalized? So believe it or not, it's the child who's more frequently hospitalized. I'll give you an example. How about a child who has sickle cell syndrome, and they come in? What do we do every time they walk in the door? We start an IV, we give them fluids, and we give them IV pain medicines. So that kid probably had some horrible experiences with somebody trying to get an IV in them and can't. So that's the child. High functioning actually tolerate it when explained to. It's the kid who's in and out of the hospital for whatever reason. A toddler has a hard time fixating on a single point. The child's eyes move cross to the midline. What does this mean? The eyes go inwards. It's like a cross eye. The eyes, the muscles are not right. And both eyes are working separately. And it's called strabismus. It's that cross-eyed. It's another word for it, strabismus. A multi. Safety in administering medications to children include what? I know one of the things that I was scared of when I started working in the newborn ICU was giving medications. And that's the one thing that made me almost not go into that. So make sure it's milligrams per kilograms, that you ask the child their name. No, because sometimes they'll tell you something different and it's really not that dependable. So always check the name band. And a room number, that's not a thing. So it's making sure the dosage is right, checking the name band. Those are the two things. What can help the parents to make a baby swallow their medicine? Or a child, whether they're toddler, whether they're also even into older preschoolers, you can get it in their mouth and they don't want to swallow and they want to spit it out. And before infection control and all that, I used to do this all the time. If you take and you put the medicine very easily, if you squirt it in the back of their mouth, they're going to vomit. They're going to choke on it. So you never do that. If you're going to put it in food or formula, it must be a small teaspoon so you get the whole thing in there. So we don't really recommend it. So you put it in the side of their cheek, into their mouth, and if you take a deep breath and blow hard, it scares them and they swallow. Now, I used to do it as a nurse, but we don't do that anymore. So we have the parent do it. So I would inform the parent how to do it. And they just want to blow easy. I'm like, no, blow really hard. Treatment for amblyopia involves what? and cover the good eye and leave the lazy eye to work. Go ahead, muscles, lazy. You need to work. And that's what we do. Excellent. Good job. The nurse is discussing sexuality with the parents of an adolescent with cognitive impairment. What's important about that? You have a girl or a boy who's cognitively delayed, who's an adolescent. What sexuality? Why do you have to discuss that with them? Think about it. You need a well-defined, concrete code of sexual conduct. There are some not nice people there who'd like to take advantage of boys and girls not cognitively aware. So you need to teach them good touch, bad touch, what's appropriate, what's not, so they don't get abused. And that's the reason why we do that. A multi. A child was asking mom about his sibling in the hospital. How can you alleviate his stress and fears? You know, years ago we didn't have FaceTime, right? Today we have it to look. But sometimes FaceTime is not appropriate. So what do you think? I've had some kids make a card for them. I've actually made ribbons for girls' hair. I've always had ribbon on me, and I would have the girl make one for her sister. Or if they're coming in to visit the child, remember noises, sounds, monitors, IVs, things, equipment can be very frightening. Have that child prepared for what he is going to see. Okay. Telling him okay, that doesn't alleviate any stress. He needs to do something, feel something, see something. A multi. What are some best practices when a child is in pain? Always give pain medicine when it's ordered and give the amount that's ordered. Distraction is amazing. It works because it takes his mind away from focusing on pain. Repositioning. If you had a child with an appendectomy and they're laying flat, elevate the head of their bed. Simple as that, right? And then we don't do any sort of respiratory treatments, whether it's incentive spirometry, coughing, deep breathing, until after the pain medicine. And why? Because they'll do it deeper and they'll do it better and it won't hurt him as much, right? Those are why all of those are correct. A multi. Critical children can be critically ill for long periods of time. How do you prevent pressure ulcers? Yes, children get pressure ulcers. And this is actually very similar to the adult world. Use diapers or underpads, keep them dry, keep them turned, rub those reddened areas using a draw sheet because, these sheets are not that, Egyptian cotton soft sheets. They're, industrial. So you can really, the coarseness can rip skins off. And the other thing is, using pillows, blankets. I used to use a little beanie babies to hold their ET tubes. And if their eyes would open, they would see their little beanie babies there. And all of that helps to keep it positioned so they don't flip over. Sometimes pillows are too big. Baby blankets and those animals work beautifully on some smaller children. And last question, a multi. Young children can be stressed by being in a hospital. How can you decrease the stress? So you would never limit the visitors unless there was a reason for it. It's the routine, the parents, and bring toys, the blanket, the jammies, the pillow, whatever they like. Absolutely. How did we do today? Number 3 was Kimberly too. Good job, Kimberly. Number 1, Haley. Good job, Haley. Number 4, Kirsten and Bree. So this is the end of this class. I'll be posting this recording as soon as I can. Remember, I want you to share your, give me whatever type of a diagnosis you would like to do, okay? And then I can get you locked in and you can have it. Anything else you need?
I have a question on one of
Yeah.
the test questions. It was about giving compressions to the infant and what you do, or not compressions,
You
but
always call the code first.
call code first.
Yep. Yeah, I knew you were going to ask that one. That's the only one you got wrong, dear. Did you
Oh.
just hear what I just said?
Okay, that's great.
Yes. It's
Okay.
always, yeah, I'll always tell anybody who's way up there, and that's the only question is wrong. Always call a code and then start compressions. It's push a button and over your head. That's it. Okay.
Perfect. Well, thank you.
Have a good day.